My name is Dr. Rodney Dennis, and I'm a urologist with Urology Centers of Alabama in Birmingham. My topic of discussion today is kidney stone disease. Kidney stone disease can be described a number of different ways. It can be a very painful, frustrating problem for the patient. It can be a very expensive problem for the insurance companies and the payers. It can be a very complex problem for the urologist and some patients and treating those stones, and it can be a confusing problem in some patients in trying to prevent them. So when I have a patient who has their first episode of kidney stones, after they get through the initial pain, there are several things that they want to know. Number one is, what is a kidney stone? Number two, why did I form a stone? And number three, how can I prevent another one? Because many patients who have kidney stones are at great risk of having another stone at some point in their life. Now, there are several types of kidney stones. There are calcium oxalate stones, which are the most common type of stone. There are also calcium phosphate stones, and sometimes a combination of the two. There are also uric acid stones, and sometimes even a combination of all three. There are struvite stones, and cystine stones, and triamptorine stones, and other rare types. So what causes kidney stones? Well, geography is one cause. We live here in the southeastern part of the United States. It's hot and humid, and patients can become relatively dehydrated, and that can increase their risk of kidney stones. But it's also hot and humid in large parts of Africa, and there's a low incidence of kidney stones in black Africans, and also a low incidence of kidney stones in black Americans, but a very high incidence of kidney stones in Scandinavian countries, where there's a very cool climate. So obviously genetics can play a role. Many of my patients who have kidney stones will describe family members who also have stones. Diet can also play a role. Sometimes patients may not be taking in enough water, or they may be taking in too much salt, or too much oxalate, or too much calcium, or sometimes not enough calcium, or sometimes they may be taking in too much protein. Medical illnesses can also cause a problem. Patients who have a problem called hyperparathyroidism are at increased risk for calcium stones. Patients who have gout are at increased risk of uric acid stones. Sometimes patients might have gastrointestinal problems or have had gastrointestinal surgeries or chronic diarrhea that can also increase their risk. And certain medicines like triamptorine or even thiazide diuretics can sometimes increase the risk. So how do those patients present? Well, everybody knows the typical horrible flank pain that patients have when they go to the emergency room. A lot of those patients and doctors think that the pain is related to that stone passing down the ureter and scraping the inside of that ureter. But that's usually not the case. Usually it's that stone passing down the ureter until it can't go any further, and then the urine starts backing up behind it, and that stretches the inside of the kidney, and the more fluid you put in there, the more pain that patient's going to have. I try to tell emergency room doctors to try to avoid forcing a lot of IV fluids in that acute setting, and when the patients go home with a kidney stone, we try to have them just drink a normal amount of fluid until the stone is gone, and then they need to start drinking a lot of fluids for the rest of their life. How do we diagnose those kidney stones? We used to use a study called an IVP, where we'd put some dye into a vein and then take a series of x-rays that would go through the kidneys. But sometimes it would take quite a while to get the information we need. Today we almost exclusively use non-contrast CT scans. It's a very quick study, and it gives us a very accurate assessment of the size of the stone and the location of the stone. And if we can get a plain x-ray at the same time, that also can help the urologist in management and follow-up decisions. How do we treat kidney stones? Well, when I started my residency at Vanderbilt, we almost always used a skin incision somewhere on the body to try to get those stones that wouldn't pass. By the time I finished my residency, we almost never used skin incisions because of the availability of much more conservative options, such as shockwave lithotripsy, semi-rigid ureteroscopes, flexible ureteroscopes, percutaneous nephrolithotomy, we have glide wires, we have ultrasonic lithotripsy and electrohydraulic lithotripsy and holmium laser lithotripsy and double J stent. So we have a lot of things that we can use to treat kidney stones, and we're very good at it. But my focus and my passion is to try to figure out a way to help prevent those kidney stones. And what I do personally is, if we can get the stone or a fragment of the stone, we'll send that off for a chemical analysis to help us determine the composition of the stone. I will also draw some basic blood work like calcium levels, uric acid, potassium levels, and we'll also take a detailed dietary and medical history. If patients have recurrent kidney stones, then we will do a more in-depth evaluation. We might take a 24-hour urine for metabolic evaluation, and sometimes we'll even repeat the 24-hour urine after ammonium chloride acid load or after a calcium or sodium restricted diet. Sometimes we will also check other blood work like vitamin D levels, chloride, CO2, parathyroid hormone levels, and occasionally we'll put patients on a medicine called potassium citrate, because citrate is one of those products that can help prevent calcium and oxalate from coming together to form the stone. Potassium citrate can also be used to help prevent uric acid stones. It can alkalinize the urine and help prevent uric acid stones, which seem to form in a more acid urine. Sometimes we'll also add potassium citrate to thiazide diuretics if patients are on that for blood pressure control. These are just my own personal thoughts on how I manage kidney stones. Other urologists have their own ways of managing and treating and preventing stones, and they may all be correct. These are my own personal thoughts, and I very much appreciate you letting me share those with you. Thank you.